Thank you very much, Tommaso, first for the invitation, second for giving me the opportunity to speak. I'm coming back to a much more classic, if I may put it like this, subject. It's about sexual dysfunction in women. And as you will see, most of these, the studies I will present to you deal with vaginal intercourse, but sexual function, of course, also in women includes all kinds of sex, as people may enjoy it on in their own way as it suits them. Well, first of all, there's one thing to say: sexuality and sexual function is an issue even in the age group of 40 and above, and until the age of 80. This is a French study actually showing that even in the cohort around 70 and 79, most people are still sexually active. I couldn't give you any explanation why there's a difference between France and the rest of the world, but obviously there is, and the authors didn't answer this question. But all around the world, people are sexually active until a very high age. So sexual health is a very important issue when you look at women's well-being, and dysfunction can occur at the level of desire, arousal, orgasm. It can be accompanied by pain disorders and personal distress. Well, we as urogynecologists, we are facing at least up to 64% of women who are sexually active and who suffer from dysfunction. And when we look at the literature, the results are quite conflicting in terms of what prolapse in particular can have of an impact on sexual function. Will it lead to improvement? Will it lead to change? Will it lead to deterioration? Those conflicting results probably reflect the differences in the various populations that have been studied in all these papers listed in this slide. Just very quickly, prolapse is a major burden, and combined with stress urinary incontinence, up to 12% of women undergo at least one surgery in their lifetime. And the thing is that we know from these studies that there is a higher risk of sexual dysfunction in women experiencing prolapse or stress urinary incontinence. Prolapse seems to have a higher impact on sexuality than urinary incontinence, but the severity of prolapse does not interfere with the severity of symptoms. We also do not really know, and the evidence is not clear whether or not prolapse surgery impacts sexuality in a positive or in a negative way. I try to give some answers to these questions in the upcoming minutes. Well, what is evident and what is clear that the whole subject, and it's been also already pointed out by the previous speaker, that it provokes shame, and that's why only 38% or even less of women will seek their physician for help in this domain. And let's be honest, the shame is not only on the patients, it's also on us as physicians, because if we look at what urogynecologists at least do in their daily practice, only a minority of them consistently screens patients for the sexual behavior and sexual complaints. There's been a review survey on all members of the American Society of Urogynecology. 2/3 only speak about sex. In the British Society, it's even only 50%. I don't know what the reason for that is, but it's just to illustrate that the subject of sexual function is not properly addressed. What we need to know, apart from anatomical outcome, is the importance of functional data or the importance of functional change after treatment, especially when it comes to surgery. So we as physicians, we like to see what's nice and what's beautiful. We rarely would like to see what's underneath, and sexual function sometimes we have the impression that it's a part of this group of things that we don't want to go into. and maybe it's because it's quite difficult to evaluate it. Why? Because we do not have a lot of information preoperatively. We not really are trained to address the partner role, and everything about sexual function evaluation is prone to bias, and there are numerous confounders when we look at that. It's the complexity of human sexuality, family and partner balance, well, the profession, the medical history, education and culture. It's the hormones, it's the surgery that she had before, it's the influence of age, and in terms of confounders is the concomitant stress urinary incontinence or urgency urinary incontinence, sexual inactivity, so women without sexual activity. What about the follow-up time? What is the right follow-up time? Given that the activity has the tendency to decrease with age, and we do not know when we have to assess these patients. Is it at 6 months, at 12 months, 6 weeks after surgery? We don't know that. Well, there is change going on after prolapse surgery, that's for sure. The vagina changes, it shortens, it narrows, it's probably sometimes even distorted. And we have sutures there in place, and whether or not we're placing them at the perineum, at the level of the levator ani, it can be symptomatic. And of course, when we use mesh, there can be complications, exposure, extrusion, retraction, we all know that. And let's not underestimate the symptoms that might be found in the partner. So there's a volatile word about hysperuria, when the partner, when it's a male partner after vaginal penetration, experiences pain or bleeding, which is caused by the fact that the mesh is eroded or too tight, and this can lead to a significant decrease in sexual function, and also could be a source of divorce, to go as far as that. So is there a modification of sexuality after the prolapse surgery? Definitely yes, because the body image most importantly can change if the prolapse is repaired. It could lead to an absence of both coital incontinence and physical bother, but there's also the problem with the scar, the distortion, as the shortening, the narrowing, as mentioned before, and maybe the vaginal sensations will be different. The patient can experience pain, and what we fear the most is de novo dyspareunia. So how can we assess sexual function? Probably the best would be questionnaires, and the problem is that the early studies about prolapse repair did not assess sexual function with validated questionnaires, which would be able to measure subjectively and objectively what sexual function is. Those questionnaires were not reproducible and were not condition specific. Now we do have a panel of questionnaires in that area. We have the PISC, which is the Pelvic Organ Prolapse, Urinary Incontinence, Sexual Function Questionnaire, which has been modified quite often. There's a short form with only 12 questions. There's another one that is the so-called IUGA revised PISC-IR. And there's the Female Sexual Function Index, which give an objective assessment of sexual function. So, what's happening here? Good. Would just like to point out what the problem was with one of these questionnaires at the beginning. If you look at this study from the Takar group in Croydon, they've assessed the PISC response in 37 women, and the problem was that with the old PISC 12 questionnaire, they had the problem with the incorrect assessment of sexuality in women without sexual activity, because women may not have sex because of a condition or because of other reasons, because they're just not interested, or just because maybe the partner is not up to it, if we're talking about erectile dysfunction, for example. And then there's also the problem with surgery-specific negative effects on sexual functions, which were not properly represented in the PIS questionnaire. So IUGA, the International Urogynecology Society Association, has revised this questionnaire, and this one now addresses also sexual inactivity, and it includes also women with anal incontinence. It was studied in a population in the United States and in the UK, and there's been a translation into 10 languages, unfortunately not in Italian, which would probably be seen as a scandal by the hopefully not future Prime Minister of this country. Well, the good thing about this questionnaire that it has a very interesting and mainly covering conceptual framework, which includes women who are not or not willing to be sexually active, and where the sexual activity may change after surgery or after treatment of their prolapse. What about vaginal surgery, which is our gynecological unique selling proposition, if I might put it like that? It's probably a dogma of the past that it can only be considered for old women, and that it includes large colpectomies or even colpoclasis. It has been rehabilitated in recent years, and is now not only because of the mesh, the pre-mesh debate mesh evolution, still a modality for women of every age. And we know that, and actually the evidence is quite good when we look at sexual function in native tissue repair, for example. Dyspareunia de novo is only at around 5%, and that doesn't seem to be a problem with the so-called G-spot, whether or not it exists at the anterior compartment. What about the apical compartment? Well, there have been several studies examining this compartment. Sacrospinous fixation, though, seems to shorten and narrow the vagina a little bit more. And when you compare this technique to laparoscopy in expert hands, there seems to be more dyspareunia in the vaginal surgery group. So there seems to be a slight advantage of laparoscopy over sacrospinous fixation, but there's still, in this study, what they've pointed out is that vaginal surgery has still a much better outcome in terms of sexual function than this was expected before. For the posterior compartment, the studies are quite equal in terms of when you compare the different techniques and dyspareunia de novo. When we look at the mesh debate has been discussed at this meeting already. Well, whether you use mesh or not, the problem is that not all of these studies have utilized the validated questionnaire, so it's not very easy to give any recommendation in terms of sexual outcome. But still, when you look at the recent incontinence ICI publication of 2016, there have been some randomized controlled trials comparing vaginal mesh and native tissue repair, and there was no difference in terms of de novo dyspareunia and PIS scores. Same for the anterior compartment. And the recommendation said that with a grade of recommendation B, that mesh is not associated with a worsening in sexual function and increase of de novo dyspareunia. For the posterior compartment, though, given that there were more severe complications, although there hasn't been any change in PIS scores, still there is an insufficient evidence for recommendation on sexual function when you put the mesh in the posterior compartment. What about the Cochrane? The Cochrane did not state any difference in different comparisons when they compared mesh with native tissue, when they compared anterior repair with mesh, when they compared polypropylene mesh with biological mesh, when they compared biological mesh with native tissue repair, there was no difference or no data available. What about biological mesh? Well, it hasn't been evaluated a lot, but it doesn't seem to give any advantage in terms of sexual outcome when compared to other techniques. What about laparoscopy? Well, this is a nice paper from Annette Kuhn and her team in Bern in Switzerland. They examined 62 patients and they did not find any vaginal shortening, which is quite reassuring, with a good result in the capacity of orgasm, satisfaction and pain significantly improved, and they stated that this technique, sacrocolpopexy, is a good option in sexually active women. The latest review about laparoscopic sacrocolpopexy from Ganatra is still already quite old, 10 years ago, in European Urology, stated about sexual health that there are still no more studies needed to evaluate that aspect after laparoscopic sacrocolpopexy. What about robotics? Well, again, here we have a very limited data available. We do not know if the robot does improve or sexual function after prolapse repair, or if it's better than any other technique. Although this prospective study from Van Zanten states it otherwise. So I come to an end and would like to give you those take-home messages. First, we need to talk about sex. It's already been stated before, at all ages. So it has to be a very important part of our assessment of not only men, but also women. And why? Because it's important that we inform the patients about their conditions on sexual health. So why does prolapse interfere? How does it interfere? And what can we do about it if we choose the one or the other intervention? Why? Because we need women to be reassured, to be confident, to look forward, and to get rid maybe of the myth that is there in a lot of women, in a lot of women's head, that prolapse does preclude sexual activity, which it does not, because it cannot harm neither her nor her partner, or before or after any repair, that lubricants may be helpful, and that they should be confident in terms of their prolapse. Again, it's very important to report sexual activity before and after treatment, whatever the treatment may be, and report whether or not dyspareunia occurs or not. And the best thing to do would be, even if they're not perfect, to use the most recent parts, the most recent versions of the available questionnaires. And the most important thing is that all approaches for prolapse repair, obviously, given the results from the literature, are compatible with good sexual health. Even if there's no clear recommendation about whether or not to use a light or a heavy mesh if you're using mesh. And there's a slight evidence that probably if you have younger, sexually more active women, laparoscopy, whether you do it by sacrocolpopexy or lateral suspension, could be the route of choice. That said, I thank you very much for your attention.
Thanks a lot, Nico.